Do I get to say my favorite soup?
Oh, yes, you have to introduce yourself, ma'am.
Okay. Let me share my screen. Hi, my name is, you can call me Andy Rogers. I'm the program director at the Positive Health Clinic here in Morgantown. Um, and I'm also an educator for the Maytech program. And I was asked to be a speaker today to talk about HIV testing by Dr. Brian. And my favorite soup, I actually have two, actually three. So I love lobster bisque at Boston Beatery. I love stuffed pepper soup at Eaton Park. And I also love potato soup that my friend makes at the tailgates at the football games. And he puts dumplings in them, and it's absolutely delicious. So a little bit about me. So I have, I'm actually a medical technologist by trade. So I'm a laboratorian. And so my passion has always been laboratory and testing. I worked in the microbiology lab for several years. And then Dr. Kaku, who was our previous chief of infectious disease, asked me to join infectious disease and do research. And I worked there for several years. And then Dr. Sawari came on board. And as he says it, I kind of roped him into writing the Ryan White grants and getting funded to provide care for patients with HIV. And then a few years later, we decided to start a rapid testing program in our clinic to provide testing for our partners of the patients that were seen in our clinic. And I'll talk a little bit about that a little bit later. So there's just a couple housekeeping slides that I need to put in here. Just one second, I'm having a little bit of an issue here. If I can move this. Okay. So this is the Maytech is funded by HRSA. That's the Health Resources and Services Administration. And it is headquartered in Pittsburgh, Pennsylvania at the University of Pittsburgh. And it also, it's the Mid-Atlantic region. We're the West Virginia regional partner, and the Mid-Atlantic region includes other folks like Johns Hopkins and Christiana Care, Howard University, and VCU, Northern Virginia, Philadelphia Health Federation, as well as the University of Pittsburgh. So the ATC program also has national centers, and there are some websites here that actually will be in an email that you will receive at the end of your, there's websites that will be included in an email that you get after the presentation. So I don't have any conflicts to disclose. Again, this is brought to you today by the West Virginia regional partner of Maytech. And so today I want to talk a little bit about, I was asked to talk about HIV testing. My expertise is mostly in rapid HIV testing. I've been out of the clinical laboratory for several years. I try to stay up to date, but I'm not going to talk about a lot of what happens in the laboratory. And I'm not going to talk about things that like Kaylee Berner has talked about in the past, which is laboratory testing, HIV testing for during PrEP or before PrEP. I'll let she's an expert on that. I'll let her, I'll leave those questions or that type of to Kaylee. But I will talk a little bit about the surveillance data that West Virginia publishes. And then I want to talk a little bit about the different HIV testing methods and some things that I think that are important for people to know that maybe we don't think about. So the CDC back in 2006 started recommending that anyone between the ages of 13 and 64 be tested at least once in their life for HIV. But it's funny because 20 years later, in a recent report, the CDC says that most patients are still not being offered HIV testing. So at the 2006 conference at the CROI conference, the CDC presented a modeling study, and they presented that just if we maximize just 3 interventions, including HIV testing, we could reduce new HIV infections by 70%. And that includes HIV infections, treatment as prevention, and PrEP. So this is a website that is maintained by West Virginia Department of Health surveillance program. And it is updated every 2 weeks. And I want to show you, if I can, let me see if I can get my laser pointer. Okay. So they update this. This is the actual website for pulling this page up. And then once you pull this page up, if you see where this arrow is, it says click here to see all new HIV diagnosis by county. This is somewhat hidden. The state did change this up about, I don't know, 6-8 months ago. And I've recently talked to some folks that did not realize that you could still see each of the HIV cases by county. And I'm going to show you on the next slide what that actually looks like. And it's going to look a little busy, but this is what it actually looks like. So we have 55 counties in West Virginia. So every 2 weeks, the state updates this site. And what it looks like now is they are listing from the year 2015 to 2024. What it lists is each county in West Virginia down along the side, and then the year, and then the number of, the total number of new HIV cases per year. And then the next column is the total number of cases that are attributed to injection drug use. And they started doing this around, well, they really started tracking this around 2017, 2018, 2019, when we started seeing an increased number of cases of injection drug use cases. So depending on where you're from, you're probably trying to squint your eyes and figure out what your county looks like. But just to pull one out for an example, Cabell County, back in 2015, 2016, 2017, they averaged about between 6 and 7 cases per year of HIV. And you'll see under the IDU column, the ones that were attributed to injection drug use, an asterisk. What the asterisk means is that there was less than 5 cases that were attributed to injection drug use. If the cases become greater than 5, then it becomes a number. So in Cabell County, prior to 2017, well, actually, let's see, where are we? prior to 2018, they didn't have cases, greater than 5 cases attributed to injection drug use. But I can tell you a story of a testing event that we did with the state health department in 2019. In the health department at the harm reduction program, we were testing folks in the harm reduction program in the health department. And the plan was to test about 200 people, and we were doing rapid testing. And normally we would test and obviously not turn up any new positives. And in February of 2019 in Huntington at the health department, we actually uncovered 7 new positives in one day in February 2019. And that's actually when we knew that we had a cluster and an outbreak situation in Cabell County. So that ended up turning into numbers here, and you'll see where the IDU cases in this column here. So in 2019, we ended up having 60 new cases of injection drug use related cases in Cabell County. That was then followed by Kanawha County. We also, back in 2018, had cases in Ohio County. And since then, we've seen cases increase in Mineral County attributed to injection drug use. But this is something that you can go and look at every 2 weeks. It's updated. And the surveillance program actually does a really good job of keeping this updated. This is just a snapshot. I made it a little bit bigger so it's not as hard on your eyes. You can see the total number of cases from 2015 to the year to date. This is through September 17th. And it hasn't been updated. I looked this morning, but I don't think it's been updated yet for October. But it should be within, it probably will be by tomorrow. So this is, when I was doing some research for this talk, I wanted to look and see, one of my strong feelings has been for years that people don't get tested for HIV. We don't do a very good job about telling people about getting tested for HIV. We don't do, even though the CDC has been recommending since 2006 that people should get tested, right? And I've often said that I don't think that people really go to health departments to get tested. It's not, so when I was researching this, I came across this document published by the CDC, excuse me, and back in 2021, they published this for the year 2021. CDC funded HIV testing sites. So this would be CDC funds HIV prevention activities. And so the CDC funded HIV test sites would be like local health departments. And this would be predominantly the tests that are done in health departments where people have their blood drawn and sent to the state laboratory in Charleston. Okay, so this wouldn't include any health departments that were doing rapid tests or anything like that. This would probably just include those health departments that are doing the tests that were funded at the state lab. But it's, to me, very sad to see that only 6 new positives, excuse me, 6 new positives were uncovered with the CDC funded HIV testing. Yet statewide in 2021, we had 153 new HIV positives statewide. So what that tells me is that 147 cases were found in public health funded sites. And we know that people aren't getting tested. So that's pretty scary to me when you think that that many people were found outside the public health system. We need to do a better job in the public health system, but we need to do a better job in the non-public health system. So if that makes sense to people, and if you think of a question and you want to put it in the chat so that we can address it later, if I didn't articulate exactly what I'm trying to get at here, I put this here mostly to generate discussion, because the bottom line is we're not doing enough testing. Okay, so now we're going to talk about, now this is fun for me. Okay, so this is my life. I love lab testing. I could talk all day about it. And so this is where we are going to understand what happens when a person comes into your office and says that they may have been exposed to HIV. And let's say that they were exposed, they believe that they might have been exposed Saturday, and they're coming into your office on Wednesday. And at that point, in the first 10 days after somebody is exposed to HIV, in the first 10 days of infection, we do not have a laboratory test that can detect HIV. But you would want to do a baseline lab at that point to establish what their baseline is, okay? Were they exposed from a previous exposure? So despite the fact that you can't tell anything from the exposure that happened Saturday, you can see what their status is from any previous exposure. So the first 10 days is called the eclipse period. We don't have a laboratory test to detect HIV infection. After 10 days, the first laboratory marker that we can detect is the actual virus, or through nucleic acid testing, the RNA. So this also referred to as the viral load. And that is the first marker to show up in the bloodstream. And this is the marker that we typically see. This is when a person may have what you've heard referred to as acute retroviral syndrome. A person may have something that they referred to as the worst flu of their life. The detectable levels that are found following this eclipse period are for P24 antigen. But let me go back to the RNA testing. We don't use this as a screening tool because it's labor intensive and it's expensive. And so this is not something that we use in the laboratory to screen people for. So it's, we then turn to the next laboratory marker, which is the P24 antigen, then followed by laboratory markers IgM and IgG. And the way that you can remember your laboratory markers, your antibodies, you're a mother before you're a grandmother. So IgM comes before IgG. The P24 antigen is a marker that I'm going to explain a little bit more in the next slide. It is a marker that in laboratory tests, we're detecting free P24 antigen. And so once your body starts producing the antigen, it naturally responds with producing antibody, and so it complexes. Laboratory tests are designed to detect the free P24 antigen. So once it complexes with the antibody, it's no longer detectable. So we're talking about a very small window period of time that lab tests can actually detect P24. So we do have tests that detect it, but it's a very short window of time. So it may be a matter of, 72 hours, 48, 72 hours that we can detect it. But it's important if you can detect it, if you suspect that somebody has acute retroviral syndrome. So it is the test that is recommended as the screening test when you're doing the screen. The CDC and the laboratory recommendations for doing screening start with the antigen antibody combination. So they're screening for the P24 antigen and the antibody assay. So if that antigen antibody screen is positive, then the next step is going to be looking to see if you can determine if it's HIV-1 or HIV-2. So HIV-1 is the most common antibody, or is the most common infection that we see in the United States. HIV-2 we see more common in Africa. It's rarely seen in the United States, but it's still part of the algorithm. So going back up to the top here, most laboratory assays, when you draw blood and send it to a laboratory, most laboratory assays today will include the antigen antibody screen, and then they're followed by the HIV-1/2 antibody differentiation assay. This is also known as the Genius test. So you may have heard of it referred to as the Genius assay. It's interesting, this Genius assay, if I go back one slide, the antibody that it detects is IgG. So it's not really going to detect early infection. So if this initial screen is positive and this screen is negative for HIV-1 or 2, or both, that means that antibody is not detected and you're going to have to reflex to a nucleic acid test or RNA, because you have to start thinking about acute HIV infection. And I hope that makes sense. And if it doesn't, please write yourself a note and I can go back and go through this again. But I have, a couple more simple examples to go through this just in case. So this is just to kind of make it simple. The antigen antibody screen for someone who has established HIV infection. So let's say somebody who has had HIV and has been infected for at least 30 days, okay? Their antigen antibody screen would be positive. Their differentiation assay would be positive for either, it would probably be positive for HIV-1 if they're in the United States. And that would be evidence of HIV infection. If they're negative, their antigen antibody screen would be negative, and then we would talk to Kaylee Berner about PrEP. An example of somebody with acute HIV infection is their antigen antibody screen is positive. This does not tell you if it's antigen or antibody, right? It just tells you it's positive. The differentiation assay, or the Genius, would be negative because, again, remember, this only detects IgG antibody, and that's for established infection, and it's negative. So as soon as you have a positive screen and you have a negative antibody, there's really only two choices. And one of those choices, if the patient clinically looks like they might have acute HIV infection, you need to look at doing an RNA test. The other possibility here, if they have a positive screen and they have a negative differentiation assay, so they're not showing antibody yet, it could potentially be a false positive. So you're going to need to do some repeat testing. Does that make sense? So I love rapid testing, and to be able to talk about rapid testing, we would need a whole lot more time, and that's not going to be today. But just so that you're aware, rapid testing is a great tool for us, and we use it all the time. And we use it for outreach events. We use it in the clinic doing partner testing. We use it disease intervention specialists. It's a perfect tool for disease intervention specialists, because disease intervention specialists go out and tell people, like, you've been exposed to HIV or syphilis. Would you like a test? And I can give you results in, we have a test that is literally less than a minute. I can give you a screening test in less than a minute, a result from a finger stick. And that's actually it's a great tool to be able to use for partner notification. But I just want everyone to be aware that if there's ever a question, the absolute best test is always a laboratory-based test, and that's with a venipuncture sent to a clinical laboratory doing an antigen antibody screen. So if there's ever a question, so let me give you an example. So last year we did an outreach in Kaiser, and we had a lot of our clinic staff went, and we did some testing, and we had a screening test that was positive with the 1 minute finger stick test. When we did the second finger stick, because that's the way our rapid testing algorithm works, we do 2 rapid tests. The second test was negative. So now we needed another test, right? To decide, now what? Always do a laboratory-based test. And as it turned out, that test ended up being sent to a clinical laboratory. The venipuncture sample was sent to a clinical laboratory, and it turned out that this was a false positive test. So unfortunately, we have to prepare ourselves that false positives do happen with lab tests, all lab tests, not just HIV tests. And so you have to be prepared for those. But in my experience, probably your best friend is talking to an infectious disease expert like Dr. Sawari, Dr. Bryan, and using clinical judgment along with the laboratory data that you have, because that communication can usually figure out, is this a false positive? Do we need to do repeat testing, or what the outcome should be? So if you want to do rapid testing, and if there's anybody watching this that has a desire to do rapid testing, there's a bunch of different things that you need to consider. I'm not going to go through these, but it's actually pretty easy. There are some things that are required by state law, but honestly, by and large, it's a matter of just getting a CLIA certificate of waiver, which is very, very easy. It's just a matter of filling out some paperwork, answering some questions, and getting a CLIA certificate. And then the HIV laboratory approval is some paperwork that has to be submitted to the state, so that you can just give them some assurance that you know what you're doing, and that you're going to go through training, and you're going to have some quality control and quality assurance programs in place. But the good news is the MATEC program offers training, technical assistance, and and I get to help, and it's my passion. And I'm more than happy to ever answer any questions any day, anytime. If you want to call, I'll give you my contact information, and we can come on site and assess the situation. If you want to have training on site or via Zoom, we're more than happy to do that. So we can help you through setting up a program, or helping to do training for your staff, or doing competencies, whatever is needed. And again, this is a short presentation because there's a lot more involved. These are just references that you'll have in case you want to look into things further. And this is just some of the contact information. Alyssa is the regional coordinator for Maytech, and Dr. Brian is the regional director. And I'm just an educator for Maytech. I do the trainings and for the rapid testing. And I thank you, and I'm happy to take any questions.
We did have one question in the chat. Promise had asked, is the HIV-2 only detected in Africa and other countries?
No, so let me see if I can stop sharing my screen. Was that successful? Yes. Am I good? Okay, so no, actually it has been detected in the United States, but it's typically transmitted in Africa. So does that answer the question?
Yes. Does anybody else have any questions?
If I could ask a question, what do people, I have no idea going into this, like what people even want to know about HIV testing, if anything. Maybe y'all didn't even want to know anything. So, and if that's the case, that's okay. But I mean, because I love HIV testing, I could talk about it all day. But, do people want to see HIV testing, like rapid tests actually done, or what is available? What are the different types? Because I kind of thought about doing that, but I really have no idea. The audience is so varied that it's hard to know. It's such a broad subject. Does anybody have any 2 cents they want to throw?
All right, I don't see anyone making any comments, and I hate to rush, but we are going to switch over to our case real quick. I want to thank you, Andy, for taking the time out of your day and sharing that with us.